We have to, but we're mandated. When we try to authorize these, the silly insurance companies, they mandate that. They won't approve a PSMA or any PET scan unless you've done the standard CT and bone scan. And they have to get on a peer-to-peer review and talk to somebody, waste my time, and tell them, listen, the CT and the bone scan are going to be negative. We're going to waste your time and money, and we're going to order the PSMA anyway. I mean, this is a kind of a recurring theme lately. It's really annoying.
How do you think it will work itself out over time, or?
I'm not optimistic.
Okay. And you have not used it at all for staging then, correct? Is that what you said? Okay.
I can see that in the future, potentially, but at the moment, no, we're not.
Okay. And then what about monitoring disease progression for metastatic patients? Ever use it for that?
Not specifically, no. But I can see that maybe in the future, but no, we don't.
Okay. And how long do your patients typically have to wait before the scan can be scheduled?
Oh, I don't know that for sure, but my sense is it's probably in the order of 3 weeks or so.
Okay. And then how long for the report?
Oh, I mean, the reports are pretty quick. Once they get the scan done, we've got the report within 48 hours usually.
Okay. And are there any better non-PSMA PET alternatives that you're aware of?
No.
Okay. And as far as research on appropriate uses, anything you'd like to see in particular?
Well, I guess maybe its role for pre-op staging, maybe.
Mm-hmm.
Yeah.
And do you think more research would help you with your insurance approvals?
Oh, potentially, sure. I think so.
Okay. So if you would, think about the most recent patient for whom you just ordered a PSMA PET scan. Can you walk me through the whole process, starting from what led to the decision to order the scan, how it was carried out, interpreted, and then how you use the results to make diagnostic or treatment decisions?
Well, it's the most common scenario. A guy who's I do robotic prostatectomies,
mm-hmm.
and in the midst of their follow-up, the PSA begins to rise. I don't pull the trigger on the PET scan when the PSA is just barely detectable. I think at least a little bit I've read about PET scans is the sensitivity isn't that great when the PSA is, less than 0.5. So I continue to watch the patient a little bit, not only to see the PSA velocity, in other words, how fast is it progressing, but also to get it to the PSA to a level where I think the PET scan will be helpful.
Mm-hmm.
And so at some point, we'll order the PET scan, and if isolated metastatic disease is confirmed, then I'll typically refer them to radiation therapy to those areas.
Okay. And is the PET scan performed in the radiology department at both of these hospitals, or nuke med department?
Honestly, I don't know the answer to that.
Okay. But it's not the radiation oncologist who does it?
I would not think so, no. Yeah, probably radiology department.
Okay. And do you think there would be a benefit to using PSMA more frequently to either diagnose or stage your patients?
Well, I think so. But, you have to balance that with the cost of medical care. I mean, we always have to be a little bit conscious of healthcare dollars.
Mm-hmm.
And so it's tough to know what the sweet spot is in terms of who you would get a PET scan on to stage the patient and who really doesn't need it. And I think that's not terribly difficult to stratify at this point. Some patients have very low risk disease, and the odds of metastatic disease is low enough that I wouldn't just obtain a PET scan on everybody.
Mm-hmm.
But certainly stratify the patients after their tissue diagnosis, and patients with higher risk disease would be the ones that I would think we would consider staging with a PET scan.
Okay, and what determines that they have higher risk disease?
Well, a number of factors. Excuse me, the PSA level, the nature of the biopsy report, the grade of the cancer,
mm-hmm.
and the findings on digital or physical examination of the prostate. So there's, the higher the PSA, the higher the grade of the cancer on the biopsy, the more suspicious the prostate exam is. On digital exam, are going to be higher risk and more likely to have metastatic disease, and ones for whom the PSMA would probably be most indicated.
Okay. And thinking about all your patients who have yet to be treated, what % of those would you categorize as high risk?
In my practice, excuse me, I would say probably 15 to 20%.
Okay. And you mentioned now that you usually use the PSMA PET scanning after treatment, and that it's a rising PSA that triggers the order. Is there any particular type of treatment that it typically follows?
Oh, you mean based on the results of the PET scan?
No, I mean, do you find that you have to order the PSMA PET more frequently after surgery or after external beam radiation or brachytherapy?
No, I don't. No, I don't think so.
Okay. Are there situations where you would like to order but you can't for regulatory or any other reasons?
Well, I think I alluded to that earlier. I mean, just
mm-hmm.
pushback from the insurance companies. So, okay. I mean, I think it's getting better. We still have to jump through the hoops. We still have to do the peer-to-peer review with the company. We still, at this point, have to order the CT and the bone scan first. So there's hoops to jump through. It's a pain in the butt for everybody. But overall, I think it's becoming a little bit easier as time goes on.
When you order a scan, how frequently do you have to do a peer-to-peer?
Well, pretty much every time I order a PET scan.
Oh, wow. And yeah. How does that work? Do you automatically do it before you order it? Or does the radiology department come back to you and say, insurance is denying this, we have to? Yeah.
I mean, I give the order to our clerical staff.
Mm-hmm.
They're the ones that schedule any type of imaging. And then they usually come back to me. Well, guess what? They won't authorize it. It's the insurance companies, not the radiology department.
Right.
But they won't authorize it. So you have to order the PET or the CT and bone. It's it's just a pain. It's a complete pain.
What do you think it would take for them to at least drop the CT and bone prerequisite?
Well, I'm hoping it's just a matter of time as this becomes more accepted, more standard of care. And if they look at their records and they see that 90+% of the CT and bone scans that they're ordering are negative, it's just hope they get the idea that it's a waste of their money. Go ahead.
Did you have to go through a similar process with Axumin when it first came out? Do you remember?
Yes, I do remember. Yep.
And how long did it take for that to settle out, if it has?
I don't think it ever really settled out, and then we just merged into